welcome everyone. Thank you for tuning in for part two of the series. I'd like to keep it going with a part three that we'll release a date soon after the conclusion of this seminar. And part one has been recorded and should be available through the Baystate homepage. So I'll get started today with the title of my talk on medications for Parkinson disease. And I titled it When and What to Take. Because at different stages of your Parkinson disease, you're going to need different medications. And that may mean starting new ones while stopping others. I don't have any disclosures. So just to set out a roadmap for today, and I'd like to guide everyone through this process, just setting the stage of Parkinson disease as a whole body disease, not just a disease that affects the brain. We also are going to spend time on what the goals are for medication. Some medications are indicated for certain symptoms and may help certain things, but not others. In addition, some medications may have associated side effects, whereas some symptoms may be related to disease progression. And so it's important to know what's the difference because there's a lot of overlap. Finally, I'll take everyone through the most commonly prescribed gold standard medication for Parkinson disease and its various formulations, other medications that help the medication for Parkinson disease, and then what's coming in the near future in terms of what we call device-assisted therapy, and I'll save that for the end. But most of the talk will be focused on the oral therapies available for Parkinson disease. So I treat patients with Parkinson disease as if it's a whole body disease, meaning it's not just a movement disorder, that there are other symptoms or comorbidities, diagnoses that come along with Parkinson disease. And so in part one, the metaphor that I used was the freight train that was coming. That was Parkinson disease as a clinical diagnosis, the movement disorder. And we went through that in part one, where patients need to exhibit slowness of movement and either tremor or stiffness in their muscles, also known as rigidity. But for the purposes of this talk, I'd like to use a slightly different metaphor called the Parkinson's iceberg. And mainly what that means or is referring to is what people are going to see on the outside, whether it's your tremor, difficulty walking, or your stiffness, and what you may feel on the inside or through your day-to-day when people aren't there all the time. And that may include difficulty speaking, loss of sense of smell, fluctuations in your blood pressure, even hallucinations. And so the iceberg metaphor comes into play when there's disease progression, and especially over the course of Parkinson disease, it's oftentimes these symptoms that are below the surface or on the hidden part of the iceberg that have a larger bearing on your overall quality of life, more so than the tremor or rigidity that you may have. So, as I mentioned in the first part of the series, Parkinson disease patients live a long time with their disease, sometimes 10 or even 20 years if they're a young onset Parkinson disease patient. So over the course of the disease, as it progresses, there's going to be different symptoms that pop up that may need treatment either with medication or a discontinuation of medications that were used in the earlier part of the disease. And so I use the term longitudinal disease because it affects patients over many, many years. And during that time, there may be other symptoms that may be at the forefront of their day-to-day that affect their quality of life. And so what I use in this graphic here is in the beginning, in the gray boxes, your patients have slowness, tremor, but in the background, underneath the surface, they may be having more fluctuations in their blood pressure, difficulty swallowing, and even hallucinations and behavioral disturbances. So what I often encourage patients to do to keep track of all these symptoms is to complete what's called a motor diary, or use a symptom tracker. What's interesting in new development in the field is using wearable technology. A lot of patients have things like Apple Watches or fitness watches that are widely available and relatively inexpensive that can track simple things like step count, asymmetry with your steps, and minutes of activity throughout the day. So let's go back to the 1960s. And in the 1960s, there is a Swedish researcher and clinician, Dr. Arvid Carlsson, who first demonstrated that the compound L-DOPA, when given to Parkinson disease animals, models, reduced their symptoms. This later led to clinical trials in humans, also demonstrating the same efficacy. And for that, he was recently awarded the Nobel Prize in the year 2000. This is him over here on the left side, smiling at these other two gentlemen who he received the Nobel Prize with during that year. These are two other famous neuroscientists, but for the purposes of this talk, the discovery of the compound L-DOPA by Dr. Carlsson was revolutionary. It was documented in a famous Robin Williams movie, Awakenings, based on the book by Oliver Sacks, of how effective it is in treating patients with Parkinson disease. And this is the chemical structure here. And it's important to note this chemical structure because the compound L-DOPA in the commonly prescribed carbidopa, levodopa is what we call a prodrug. So it still needs to get turned into dopamine along the pathway from mouth to brain. And I'm going to go into that next. So where is the problem in Parkinson disease? Well, we know that it's a neurodegenerative disease, meaning a loss of brain cells in a certain area of the brain. And in this case, it's a part of the brain called the midbrain, which is part of the overall structure of the brain stem. So not in the cortical areas of the brain, but in the deeper parts of the brain. And on the left, you can see on a pathological sample of a human brain, a healthy control, there's dark areas that have stained, and that's for looking at the areas where dopamine is produced. However, in a Parkinson disease brain, we see that there is a loss of the dopamine neurons or brain cells. And there you can surmise that if we're losing the brain cells that produce the chemical dopamine, how are we going to replace that? Well, thanks to Dr. Carlsson, we discovered a prodrug, L-DOPA, which taken by mouth can get turned into dopamine and replace the lost dopamine from Parkinson disease. So let's follow the path of a carbidopa, levodopa tablet that someone takes, that a patient takes. So when someone takes their tablet, they oftentimes take it by mouth, or they have to crush and dissolve it in a liquid, which I sometimes recommend to patients who have difficulty swallowing. Once it's swallowed, it passes through the stomach. It's not absorbed in the stomach, and that's key for patients to understand. The medicine does not get absorbed in the stomach. It has to pass through the stomach, through the first part of the small intestine, where it gets absorbed. So once absorbed through the first part of the small intestine, it makes its way over into the bloodstream. Now, once the chemical L-dopa or levodopa is in the bloodstream, there it has to get transported across what's called the blood-brain barrier that separates our brains from our blood supply. And it does that through a transporter. So there's a transporter that takes the L-dopa or levodopa and transports it across the blood-brain barrier into the brain itself. Once the levodopa is in the brain, the remaining dopamine nerve cells or brain cells take up the levodopa, and that's where it gets turned into dopamine and spit out at the end of the nerve terminals and helps us move. So the more dopamine, the more movement. Less dopamine, less movement. It's as simple as that. But where it becomes more and more complicated is how can we get patients a steady state or steady concentration of dopamine in their brain? So to do that, there have been multiple ways companies or drug manufacturers have manufactured levodopa so that we can try and achieve this steady state or steady concentration of dopamine in the brain. So it may be confusing at first, but at the end of the day, it's the same compound being packaged in different ways and released at different rates that determines what formulation of medication your neurologist or me may prescribe for you. So just to make it simple, there's an immediate release formulation, a controlled release formulation, meaning it's a long-acting, evenly dispersed formulation. And then there's a proprietary combination of a mixture of immediate and controlled release. The brand name for that is Rytary. So although there may be different formulations of carbidopa, levodopa, it's the same active chemical that we need for patients to get turned into dopamine once in the brain. Now, a parallel to levodopa are the class of medications called dopamine agonists. So dopamine agonists, the difference is that these are synthetic molecules that have been manufactured or discovered by pharmaceutical companies. So they're not a naturally occurring substance. Nevertheless, they bind to the dopamine receptors in the brain almost as good as dopamine, if not better than dopamine. And this can be both good and bad. When there's tighter binding to the dopamine receptor in the brain, we get a more measurable effect on patients' movement. They're able to move quicker, they may have less tremor, but because the compound binds so tightly, it's susceptible to developing adverse effects. And what we see with the use of dopamine agonist therapy over time, and these medications namely are pramipexole and ropinirole is that patients develop impulse control disorders and are more susceptible to hallucinations and blood pressure, lower blood pressure. But the upside is that they're associated with less dyskinesia, especially for patients who are in the early stage of the disease. The other benefit is that there is a medicine called rotigotine or a Nupro patch, which is one of the only transdermal available treatments for Parkinson disease. So has utility if patients are in more advanced stages of the disease and cannot swallow or take tablets by mouth reliably. There may be a role for a transdermal rotigotine patch. Now, this sets up a debate. So if patients have already on board with starting a medication, which medication is the best choice for them? Well, we've done work looking at that. But first, what I want to drive home is this concept of what we call motor fluctuations in Parkinson disease. And so what this graph tries to accomplish is that over time, progressing from mild to moderate to severe Parkinson disease over, say, 10 to 20 years, patients are going to have more and more of a loss of those dopamine brain cells. When there's significant loss of dopamine brain cells, the concentration of levodopa in the brain can start to fluctuate quite significantly. And that's what this sinusoidal wave pattern is trying to accomplish or show, is that in the severe or moderate to severe stages of the disease, patients are flipping from one end of being able to move too much to not being able to move at all. And that's the classic motor fluctuations that we see in moderate to severe Parkinson disease. And that's solely because we cannot maintain a steady concentration of levodopa in the brain due to those limited factors I went through before with absorption and crossing the blood-brain barrier on the other slide. So how did we settle this debate of whether or not patients should be started on levodopa or a dopamine agonist like pramipexole or ropinirole? Well, they did this study looking at a group of patients with Parkinson disease and put them into two groups. One group where they delayed starting levodopa, called the levodopa sparing group, and then one group where they started levodopa early after diagnosis. And what they found after they followed these patients is that, yes, the levodopa sparing group had low likelihood of developing dyskinesia. However, they had longer-term side effects associated with dopamine agonists, such as impulse control disorder. However, the early levodopa strategy group, yes, they had some dyskinesia, but overall, their quality of life was better and their functional status was better. And so what we've set up for ourselves here is a paradox where patients who start levodopa right away, they have overall less early disability with some dyskinesia, whereas in the levodopa sparing strategy, there's more early disability, meaning that in the levodopa sparing group, patients are often undertreated. And that's what leads to high early disability. So this is why when I recommend to patients an initial therapy when they come to see me, unless there's a good reason for going on a dopamine agonist I often choose the levodopa strategy. So being on carbidopa, levodopa, I'd say is the way to go, at least when you're starting off medication, unless there's a good reason or side effect that you experience and if you have medical comorbidities, we'll reserve for dopamine agonist therapy. Now, what are the other medications that are prescribed along with levodopa? Well, we have what's called COMT inhibitors, and those are called entacapone, and the newer medication in this class called opicapone. That's also known as Ongentys and Comtan. We also have the monoamine oxidase B inhibitors, which are known as rasagiline and selegiline. The goals of these medicines are to extend the half-life or the effect of levodopa in the brain. So if we go back to that slide where patients are fluctuating between an on state and an off state, the goal is with those helper medicines is to achieve a steadier state, meaning longer peaks and valleys between the on and off states. So extending the effect of levodopa without causing dyskinesia. In some cases, when we add on entacapone or a COMT inhibitor, patients have to decrease the amount of levodopa overall due to dyskinesia, and that's common and expected. The other class of medications used to treat Parkinson disease are a class of medicines called anticholinergics. And for the purposes of this talk, we'll be talking about amantadine and the other medications in this class, trihexyphenidyl and benztropine. Amantadine has a dual purpose in Parkinson disease in that it's used to treat both tremor and dyskinesia. So if a patient is prone to developing dyskinesia or the larger uncontrolled movements associated with levodopa, a trial of amantadine is often indicated. In addition, amantadine is a good tremor agent. So if the goal is patients want to achieve better tremor control, amantadine may be a good option. Now, amantadine comes in multiple formulations. One of them is generic amantadine, often taken twice a day. But there are other longer-acting amantadines. The brand names are Gocovri and Osmolex. Oftentimes, patients have to go through a trial of amantadine in the generic version before trialing either Gocovri or Osmolex. Lastly, medications in this class are used primarily to treat tremor in Parkinson disease. Are trihexyphenidyl and benztropine. These are medicines also referred to as Artane and Cogentin. I often reserve these medications for patients who are younger onset Parkinson disease, who do not have any signs or symptoms of cognitive impairment or other medical comorbidities, as these medications can often lead to confusion and other unwanted side effects. I would not be surprised if someone who is on trihexyphenidyl or benztropine early in the course of their Parkinson disease later has these medicines taken away for that reason. I would say the same goes for amantadine, as the major serious side effect that's associated with amantadine is visual hallucinations. So where are we in the timeline of medication discovery for Parkinson disease? Well, this is a slide not meant to overwhelm patients, but to provide hope. And I haven't even updated this slide for the past year or two But as you can see, since the discovery of levodopa after the 1960s and when it was applied for use in humans to the late till now, there's been more and more approval for medications used to treat Parkinson's disease, whether it's treating their on and off motor fluctuations, their dyskinesia, or other non-motor symptoms. So the opportunities to help patients with Parkinson's disease are continuing to increase. And I hope that this provides people with hope. I constantly try and revise this timeline to reflect that. So what are the newest medications that have been approved for treatment of Parkinson's disease? So the whole goal in helping patients with Parkinson's disease is improving the amount of on time that they have throughout the day without what we call troublesome dyskinesia, or the uncontrolled larger movements. So on time, I would define as a patient's able to move the way they want to move without significant rigidity, tremor, or slowness. So the first medication is Noreonce, or istradefylline. Istradefylline is almost like a chemical compound similar to caffeine in that its goal is to improve patients on time. It's a different mechanism of action than levodopa, as we discussed. So oftentimes, if patients have had I've hit a roadblock with their dose of levodopa, whether it's they're having problems with low blood pressure, or they're having problems with dyskinesia, oftentimes it's worth a trial of istradefylline. Xadago, or safinamide, is a similar medicine to the ones we already discussed in the helper class of medicines, and it is a selective MAO-B inhibitor, similar to rasagiline and selegiline. However, it's reversible, whereas the other ones are irreversible. And finally, opicapone is another one of the helper medications, similar to entacapone, but it's dosed once a day and is slightly more potent. So instead of taking an additional entacapone with each dose of levodopa, patients only have to take opicapone once a day with the same, or if not better, effect than entacapone. However, I do want to just present those newer medicines with a caveat that because they are newer and proprietary, they may come at an increased cost at the pharmacy, and oftentimes a prior authorization is needed, meaning you have to demonstrate that you've had ineffective treatment or failure of one of the other medicines that we discussed earlier prior to getting one of the newer medicines approved. I'm going to lastly touch on rescue medicines today. So these are medications used to treat Parkinson's disease during patients' severe off time, or times where they cannot move, they feel slow and rigid, almost as if they're having a stroke, but it's due to their Parkinson's disease. And so two medications today that I talk about, one is an inhalational form, almost like an inhaler used to treat asthma or COPD. It kind of looks like a musical instrument called a kazoo. And you would insert the capsule. It's a powdered capsule. You puncture the capsule with the device, and then you have to breathe in the medication What's important with this rescue medicine is that the patient doesn't cough the medicine back out. So if possible, what I recommend to patients is after they do the inhalational levodopa is to have a glass of water or a sip of water so that they don't cough the medicine back out. If it gets coughed out, it's not going to be effective. The other rescue medicine, and I have a demo with me on video today, is a injectable pen of apomorphine. So apomorphine is a analog to dopamine in that it can bind the dopamine receptor, but it can be injected, whereas levodopa, unfortunately, cannot be injected. It needs to be taken by mouth, or I'll talk about it later, being infused through a subcutaneous route. But the Apokin pen is similar to an EpiPen or a pen used to inject insulin. And I have a demo version here. So it's a small needle, about 2 centimeters long. And the patient, during their off time, or a family member or aide would dial in their dose on the meter here. So say the patient is prescribed to take 0.2, they'll twist the device to 0.2, screw on the needle, and then inject the needle, it's very small, into one of the recommended injection sites, usually on their leg or abdomen, is fine. And usually patients will have good response to these. Usually within 10 to 15 minutes, they start to turn back on and be able to move again, be able to take another dose if needed orally of their levodopa. I crossed out one medication is no longer available. This is called Kinmobi. But just for completeness, some patients may still be taking this medicine. It's been discontinued. It's a sublingual apomorphine that's dissolved underneath the tongue or on the tongue. So there doesn't need to be any swallowing. You just put it in your mouth, and then it gets absorbed sublingually. Unfortunately, that medicine now has been discontinued. Now, I talked about this iceberg in the beginning of the talk as the metaphor for treatment of Parkinson disease, because I spent about 30 minutes now talking about treatment used for motor symptoms of the disease, namely tremor, slowness, and the stiffness in Parkinson disease. But that would be missing the boat if we did not treat the other symptoms, the non-motor symptoms that come along with Parkinson disease, because remember, whole body disease, longitudinal disease. In the beginning, oftentimes patients are most bothered by their motor symptoms, but what the research has been shown is that their non-motor symptoms have greater magnitude of bearing on their overall quality of life. So recognizing if there's an untreated mood disorder, whether it's anxiety or depression, and treating that is treating their Parkinson disease. Same goes if they have untreated constipation, sleep disorder, or problems with regulation of their blood pressure. I'm not going to go into all of the treatments for these issues, but it's important that we recognize these problems as part of Parkinson disease and that we treat them accordingly. Oftentimes, I don't spend a lot of time during the visit talking about patients' movement symptoms. I spend a lot of time talking about their non-movement or non-motor symptoms. So if we can break things down into individual problems and treat those, we're going to elevate and improve patients' quality of life. And if anyone wants me to go into these individual problems at the end of the talk, I will be happy to answer any questions regarding these treatments. Now, what's coming in the near future, and what I mean by in the near future, this was research in new treatments for Parkinson disease that were just presented at the International Congress of Parkinson Disease and Movement Disorders, which I attended in Copenhagen, Denmark, this past month. And there's been exciting work and pending, hopefully, FDA approval of a subcutaneous infusion of levodopa. And just to give you the backstory on why levodopa cannot be infused intravenously or subcutaneously prior to now is because the compound of levodopa is very hard to dissolve. So chemists needed to come up with a way to effectively dissolve the levodopa to get it into a cartridge so that we could administer it this way. If we were to dissolve the levodopa taken by mouth, it would take a gallon, almost over a gallon of solvent in order to dissolve it completely, such that it would be safe to infuse subcutaneously. However, now we have the technology and the chemistry to dissolve levodopa, to administer it safely subcutaneously. And this is a picture on the right-hand side of your screen of the subcutaneous pump that would infuse a continuous supply of levodopa for a Parkinson disease patient. And it's been shown now in phase 3 clinical trials that it decreases the amount of off time while improving their on time without dyskinesia. So achieving all 3 goals. The study had met its endpoint and hopefully is going to be approved here in the United States sometime within the next year. This pump system is actually built off of the system that's already FDA approved called the Duopa system. And Duopa is a surgically placed jejunostomy tube that's hooked up to a pump that continuously administers levodopa gel into the small intestine. Again, what the goal is to achieve a steady state of levodopa concentration in the brain to prevent patients flipping from an on state to an off state continuously throughout the day. Now, we know that the intestinal gel infusion works and it's FDA approved, but it involves a surgical procedure and placement of a tube into the abdomen, which patients often are not happy or keen on. What I think is going to really change how we treat Parkinson disease in the near future is the rollout of these subcutaneous infusion pumps, similar to how patients wear insulin pumps. And that's exactly the technology that they use to deliver this new levodopa. So there's going to be 2 systems that will likely get approved. One is where you have 2 sites for infusion here, and one that uses 1 site for subcutaneous infusion. And the device itself will be programmed by the neurologist, which would be me, to deliver a continuous infusion of levodopa such that patients don't have to take medications by mouth and may experience less dyskinesia and off time. So I did want to provide everyone today with some homework, because when you come to see me or when you come to see your neurologist in the clinic, they're only seeing you for, say, a 30-minute visit, or if you're lucky, a 60-minute visit for your initial visit. they're not with you all day long. So getting a report back from the patient on what are the troublesome times of day, when are they having off time, is sometimes difficult to flush out in 30-minute visit. So what I encourage patients to do is track their symptoms. And you can do this the old-fashioned way, which is the way that I introduce the concept to patients, is by filling out a motor diary. There's a open access version on the Veterans Administration website, parkinson.va.gov. That's free and available to everyone. That's this worksheet here, where patients pick a day of the week and go through 24 hours of when they feel on versus off or on with dyskinesia, which will help us guide therapy in picking their medication schedule. In addition to that, there's a mobile app available through the American Parkinson Disease Association. Again, it's free, available to anyone who wants to download it onto their mobile phone. It is a little bit more specific with symptom tracking. So you don't have to track every symptom, but you want to make sure you're paying attention to patterns that you're having throughout the day so that you and your neurologist can decide on what the best treatment is going to be for your stage of Parkinson disease, whether it's mild, moderate, or severe, and how much of the day you're in the on or off state. Finally, another exciting development in the field, and a lot of research was presented at the International Congress this past month, was the integration of using technology such as an Apple Watch or fitness tracker device to track patients' symptoms, whether it's their activity level, step count, even their degree of arm swing throughout the day, and using that to tailor their medical therapy. So, for example, if activity level slows in the early afternoon, which is often a troublesome time of day for Parkinson disease patients, we can use that data on each individual patient to individualize their treatment therapy. Now, I'm not saying that everyone needs to go out and buy a fitness tracker or Apple Watch, but these are alternative ways of tracking symptoms to inform us on how to better treat your Parkinson disease symptoms and improve your quality of life. And finally, what I also want to drive home with the talk today as part of your homework is not ignoring the non-motor symptoms that come with your Parkinson disease. So if you are feeling more down or depressed, you need to discuss that with your neurologist. If you are having lightheadedness or fluctuations in your blood pressure, we need to discuss that at your next visit. The visit should not always be about tremor or stiffness or dyskinesia. If we focus on symptoms at various stages of your disease that are having a greater bearing on your quality of life, we're going to better treat you as a patient overall. Again, Parkinson disease is not just a movement disorder. It's a total body disease, and we need to treat it as such. With a more continuous delivery of levodopa, we can get there, but not all the way there. And so keeping track of the non-motor symptoms is another key piece of your overall treatment plan. And so with that, I just want to close and take and answer as many questions as I can. I have about 15 minutes left in the seminar today. I'll have Sue just guide me through some of the questions.
Sure. Thank you very much, Dr. Martin. That was really great. And I enjoyed your cartoon.
Thanks.
And of course, the other fascinating content. We do have a few questions. And the first one is Is it possible that someone's brain may not, at some point, not have any dopamine that would make L-DOPA ineffective?
That's a good question. I hope no patient ever gets to that point. But in that same thought, as the disease progresses and there's less dopamine brain cells left, it becomes harder and harder to achieve that steady concentration of levodopa in the brain such that we can treat their disease effectively. And so one way we get around that is sometimes we have a conversation with patients earlier in their disease course who we see going in that direction, considering an advanced therapy for Parkinson's disease. And when medication therapy has its limitations, early discussion of an advanced therapy, such as deep brain stimulation, device-assisted therapy. So the term you'll hear now is device-assisted therapy, and that's going to refer to those subcutaneous infusion pumps as the device assisting their therapy. So, and that will be considered almost like a bridge or an advanced therapy. It's still yet to be determined right now how it's clinically going to be applied, but more fits the role of an advanced therapy without a surgical intervention. So to tie that question together, if we see someone heading in that direction where there's less dopamine cells left, we're going to have a discussion, or you should have a discussion about an advanced therapy such as deep brain stimulation or device-assisted therapy.
Excellent. Thank you. The next question, what would be a good reason to not start on L-DOPA early?
Okay. So a good reason I'd say not to start on L-DOPA would be a patient who is working full time. They're not bothered. Say they have a tremor on one side of the body. It does not interfere with any of their daily activities, and they're still enjoying activities and hobbies that give them fulfillment in their life. What I often do is I will have that conversation with a patient and not schedule their follow-up for at least 6 months, because the disease is a slowly progressive disease. And so taking a snapshot earlier than 6 months is probably not going to be too much of a change to see a clinical difference when they come to see me in clinic. But we'll have that conversation again in 6 months and say, hey, are you still able to go to work Monday through Friday? Are you still able to take care of your grandkids? Are you still able to drive without making any errors or getting pulled over? Some of these things are on a patient-by-patient basis where we decide. But if you're functioning the way you want to function and enjoying things that you enjoy out of life, there may not be a reason to start a medicine. The other reason would be if you're considering enrolling in a clinical trial. So oftentimes, enrollment in a clinical trial, you have to be what's called levodopa naive or not started on levodopa. So that would be another consideration, is if you did want to get involved in clinical research, some of the inclusion criteria or exclusion criteria, if you're started on a medication, they will exclude you from enrollment in the trial.
Excellent. Thank you. Next question. Can you repeat the URL for Motor Diary VA affiliated?
Yeah. The URL for the Motor Diary is parkinsons.va.gov. and you should be able to find it through that website.
Terrific. Thank you. Next question. Sorry if I missed this, but how should we approach Parkinsonism caused by antipsychotics?
Yes, so that's a good question. Oftentimes, we want to first establish whether or not patients' symptoms of Parkinsonism are caused by Parkinson disease or a medication effect. Sometimes it's very difficult to distinguish between the two causes of Parkinsonism. So how we do that is oftentimes we order a DAT scan, or we work with the psychiatrist or mental health provider on finding an alternative medication for the patient to transition to, with the hopes that their drug-induced Parkinsonism resolves or improves. If it does not improve after trial of weaning off or switching antipsychotic medication, an alternative explanation for their Parkinsonism should be explored, such as Parkinson disease, and therefore a trial of levodopa may be appropriate.
Terrific. Thank you. Next question. How do you determine someone's dopamine levels?
So we do not for example, what you may be getting at is there a blood test for dopamine in the blood or in the brain? The answer to that is no, we do not routinely check dopamine levels in the brain or spinal fluid. For research purposes, that has been evaluated in the past to look at whether or not levodopa administration orally affects or helps raise those levels, and we've proven that, and that is not debated. But in terms of our clinical practice of how we treat Parkinson disease, we do not check dopamine levels in the brain. To do that, we would have to do a lumbar puncture and collect the patient's spinal fluid, which would be too invasive of a procedure to achieve what we're trying to achieve. We often use what the patient tells us or their examination findings in the clinic to inform treatment. And that's why keeping a motor diary or using a symptom tracker is important, because that can individualize your therapy rather than relying on a dopamine level.
Excellent. Thank you. The next question, are there any supplements or vitamins that you would recommend that I should take in early stage Parkinson's disease?
Yeah. So I'm actually going to devote a lot of the next part in the series to diet, lifestyle, and exercise for Parkinson disease. But just to briefly get at your question, one thing that was recently presented at the International Congress for Parkinson Disease is starting a probiotic supplement to help with GI health and constipation. And specifically, what I'm recommending now to patients is a liquid form of their probiotic supplement, and to have at least four strains of bacteria in that probiotic supplement. Now, there are vitamins that have some data to support their use. They're namely the B vitamins. So vitamin B12 can be helpful. I also recommend, if patients have a history of osteoporosis, that they be supplementing with calcium and vitamin D. Patients with Parkinson disease often are prone to falls. So if we can prevent them from breaking bones if they were to fall is something that's important to me. So that's something that I recommend to patients as well.
Very
But
good.
I'm going to cover more on that during the next part of the series.
And the next question regarding specific foods you'll cover in your next presentation.
Yes. So in the next talk, I'll be talking, there's a diet for overall brain health, which is a combination of the Mediterranean diet and a low salt or DASH diet. And that's called or termed in the literature as the MIND diet, MIND. And so I'll spend some time during the next part on the series talking about the MIND diet for overall brain health and
Terrific. Well, I'm looking forward to that. We are at time, and it looks like you've addressed all the questions in the queue.
Okay.
So I'd like to thank our attendees for the great questions and for joining the talk today, and to Dr. Martin for sharing your expertise with us. Thank you for this great presentation.
Thank you. Thank you all for attending.